Hello, everybody. My name is Preeti Minhas, and I'm the Assistant Director of Clinical Learning at Education for Health. Welcome to this series as part of our World Asthma Day. And today we'll be focusing on the role of objective measurements in asthma. We'll be looking at what that looks like in diagnosis, when someone has poor control, and what this looks like in acute situations. And to share this podcast with me today, I'm absolutely delighted to welcome Dr. Andy Whittamore. Welcome.
Hiya, Preeti. How are you?
I'm good, thank you. Can we start by you telling us a little bit about your career, some of the groups that you sit on, and your various roles that you undertake?
Of course. So, for those who I haven't met before, I'm Dr. Andy Whittamore. I'm a GP based down in Portsmouth in a large single practice PCN. And going back to when I first started as a GP partner, about sort of 2003, 2004, I was given the poison chalice of being the respiratory lead for the practice. Other partners had already done it and didn't like it. And as the newbie, it was given to me to carry on that mantle. What I realised very quickly, though, was the nurses that we had in our team were excellent, and I needed to upskill myself to be able to keep up and give them the support they needed. And this isn't meant to be a plug, but I did an education for health module in asthma and COPD. I think I was the only GP to have done it at the time.
Oh, wow.
And that gave me the confidence to get involved in the respiratory community a bit more. I joined PCRS and their leadership program, which I highly recommend for anybody who's got a team or helping to develop services. I got involved with the national strategy for asthma and COPD as a regional lead down here in sort of Wessex region. And from there, my career's taken a couple of different turns in the respiratory field. I've worked with with Wessex AHSN as one of their respiratory leads when they started working as an organisation. And then I came to a bit of a hiatus. I was finding it hard to juggle being a GP and getting more involved in respiratory. So I was trying to decide which one I wanted to ditch. Then, as luck would have it, Asthma UK were advertising for a clinical lead for exactly 2 days a week. And I've been there ever since through the merger with BLF. And the role is amazing. It's really varied. I get involved making sure everything is safe and up to date and help with the clinical development of things. I manage to dip my toes in policy and media and other things as well. So it's extremely varied. No 2 weeks are exactly the same. And I get to sort of meet people like you and come on podcasts like this.
Yeah, no, we're absolutely delighted. And you certainly, as you said, your career has taken a lot of turns, hasn't it? And it's great to see that because it gives some pathway direction for those that may be in a similar place to you in terms of what they need to do as their next career move. So like we said, today we'll be covering objective testing. So should we start by discussing what that looks like in the role um, of diagnosis and from your own personal experience as well, is just to share a little bit more around, yes, we have the evidence-based practice around it, but actually what does that look like when you bring it to life?
So this last couple of years, I've been involved in the project with NHS England trying to get a rollout of Pheno into primary care. And that has allowed me to really look at what we do in terms of diagnostics and objective measures, and has actually changed my practice personally. I'm actually working very differently in how I manage patients and diagnose patients. So going back to real basics, asthma is a really difficult condition to diagnose and to assess. We know that its symptoms are caused by inflammation and bronchospasm, and this is very variable. So it comes and goes over time. Some patients even have months or even years without symptoms. It just needs the right combination of triggers to set them off. And asthma symptoms are also very common and non-specific. For example, there are many other causes of breathlessness, cough and wheezing, all of which affect people differently. And people with asthma get those things. It's not always due to the asthma either, which makes it even more complex. One of the first things we did at the Pheno project was actually have a look at the BTS sign evidence tables in the guidance. And what it really showed me there is if we're using symptoms to diagnose asthma, in adults and in children, it's really low sensitivity and specificity. So actually, a lot of the time, we're guessing whether a patient has got a diagnosis of asthma based on symptoms. And we also know that tests are not as reliable as they should be. We need new tests in asthma and other lung conditions. For example, peak flows are only 46% sensitive, which means it's really hard to rely wholly on peak flow. Spirometry not much higher at 69% and FeNO 88%. So even that's not ideal. So what we decided to do is, rather than teach everybody that they should be doing FeNO, we wanted to teach them how to look at diagnosing asthma better. And the way we sort of looked at this was considering asthma diagnosis and assessment as being like a jigsaw. Any one of those items, some history, examination, peak flow spirometry, FeNO, even trial of treatment, gives you a little bit of the picture. And the more bits of the picture you can put in, the more certain you can be of what that diagnosis is. And unfortunately, and GPs are good at their clinical skills and clinical guesswork is, I suppose, what I'd call it. But actually, without adding more and more pieces to that jigsaw, there are a lot of those guesses which are probably incorrect, unfortunately. I think it was Aaron's in Canada who did a study of people with asthma diagnosis and found that as many as a third are probably incorrect. And from my own experience, I know there's many more people out there who are underdiagnosed. So there's a massive issue there, which then means that people have got an asthma diagnosis and not getting treatment for the condition they've got. They've been given ever expensive medications, which is placing a burden on the NHS, but also causing patients symptoms and not making them better. And on the other side, you've got people who aren't getting the treatment they need and are causing long-term damage to their lungs, still getting flare-ups, chest infections, time off school, time off work, and that's causing long-term problems for them as well. So that there's lots that we need to do to try and get diagnosis better.
And as you said, it's not just one objective measurement. It's building that picture and speaking to the patient to get that really person-centered approach care as part of your asthma management as well.
Exactly. And I think actually history taking is something we need to do better. People who've been through various courses and diplomas and modules on asthma, they know the right things to ask, but quite often these things are squeezed into short appointments or with patients coming with many other conditions at the same time. And sometimes we do have to rely on guesswork. So the more we can do to sort of take a better history, listen to chest better, and then build in those objective measures means we've got a greater chance of getting it right for our patients.
Great. So that's really the start of diagnosis. So in terms of when someone has poorly controlled asthma, how do those objective measurements change and what should be doing? Again, looking from your own personal experience, how does that change when we do have a patient with poorly controlled asthma symptoms?
I mean, changing tack slightly here is we've had issues in our practice about patients with COPD overusing their rescue packs of antibiotics and steroids. And what that's taught us to look better at it is how we actually diagnose exacerbations of asthma and COPD. And also how can we rely on patients to do better if we're not doing it well either. So coming then back to asthma itself, we find that patients, especially during COVID, where we shifted to remote consulting very, very quickly, patients are phoning up with asthma, telling us their asthma is worse, and then us sort of on the phone, then treating them with different inhalers or with steroids and antibiotics. And quite often, looking back at their case, it wasn't the asthma that was causing their symptoms. People with asthma can get reflux, they can get breathing pattern disorder, they can get anxiety, they can get coughs due to simple viruses and postnasal drip. It isn't just a question of adding in more medicine to treat the underlying asthma, although that must be considered. So certainly something we're sort of looking at a lot more is a more detailed history to get better information about what their flare up and their symptoms are looking like. And then objective measures such as peak flow to try and see exactly what's going on. In our practice, we've been using FeNO as well. So for patients not who are unstable with an exacerbation, but with maybe an increase or poorly controlled symptoms. And what it's done is I suppose, given us the confidence to tell somebody it isn't their asthma causing their symptoms. It can confirm they're getting symptoms or due to the asthma, but I think the most striking thing was actually telling people it wasn't due to asthma. Going back before FeNO, we were increasing people's medication. We were guessing at whether we should be doing that or not. We were guessing to some extent whether they were consistently using the medication and guessing whether they were consistently using it correctly, having good inhaler technique. And what Pheno gave us a chance to do is actually, if they had a low Pheno level, it meant that we could actually confidently say to the patient, your asthma's okay. Clearly, your inflammation is being suppressed and controlled at the moment. There must be some other reason why you're getting this breathlessness or this coughing or the other symptoms that you're getting. And quite often we're identifying breathing pattern disorder, anxiety, reflux,
Yeah.
and some simple things like that. There was one particularly striking case of a 12-year-old boy who came to see us because he was on the top end of medication for his age group. And he'd been on that for a few years now, but he was still getting lots of symptoms and overusing his reliever medication. What the a low Pheno level allowed us to do was really engage in what was going on. He was using his medication because he had learned that whenever he was breathless, he needed to use his inhalers. And he was getting breathless because he played football every night of the week, and at school at playtime and at lunchtime.
So a
So
very active young boy.
he was very active, but he had associated every bit of breathlessness and every cough with it being his asthma. And of course, mum was worried, came to us, we'd increased his treatment. There was also a situation because he had asthma and because he was getting symptoms, on 2 occasions, other GPs in the practice had given him oral steroids, which were not necessary looking back on it.
Yeah.
Very hard to do with remote consulting and with worries about children and reliability about peak flows sometimes. But what Pheno allowed us to do was actually really wind the clock back and then start to really work with mum and the boy about what was actually going on with his lungs and what symptoms. And actually, we're now using peak flow with him so that he can monitor himself and work out when his symptoms are due to asthma and when they're not. And that's been really, really useful.
So I guess in that example, not only have we improved the outcomes for that patient, but actually we haven't almost prescribed in lots of other medicines, which again would be a burden on the NHS and that wider economical factor as well.
Well, we've saved hundreds of pounds a year on his medication that was probably causing him side effects, medication that might have been stunting his growth and his development as well, if you're looking at the oral steroid side of things. And I think that's crucial. But actually, we were at that time consigning him to a life where he was completely ruled by his symptoms, and symptoms which were probably normal. He was probably getting no more breathless than me if I tried running around the garden with the children.
Yeah, no, absolutely. And like you said, he sounds like a very active 12-year-old. And it's great that in that respect, actually, we say a lot where people may think they can't do exercise because of their asthma. We've talked a lot about myth busting, haven't we? So again, that's really given him that quality of life or those goals in his life that he wants to achieve, particularly with his football, which I know with my son, football, he's football crazy. So I can completely understand and share that.
Yeah, so I think we look at how we worked before we had Pheno. We would guess and we'd increase the medication and see what happens, or we'd put them on a higher dose and then refer them to. In his case, it would have been referring them to a paediatrician. But actually, we had the confidence and could give mum the confidence that we were doing the right thing by actually reducing his medication.
And it gives them some confidence as their mum or their carer, they can see how all of these things are really going to enhance their child's quality of life.
Yeah, and but on the other side, we also know asthma is a dangerous condition. It does kill people still, and what the clinicians in our practice and the parents didn't want to do was to put him at risk of asthma attacks. So actually treating what they thought was asthma was the most important thing. But actually getting the accurate diagnosis in somebody who did have asthma, but his symptoms weren't caused by asthma, was absolutely crucial.
Great. So we've talked so far around the role of objective measurements in asthma in diagnosis when someone has poor control. So I guess let's move on to discussing the role of objective measurements in asthma in acute situations.
So firstly, I think there's been a massive shift in how we work in general practice over the last couple of years. We're doing a lot more assessment and treatment of patients over the phone. And because of that, history taking needs to be much better. So again, looking at that jigsaw approach to what people's symptoms are due to, sometimes you really do need to delve in to try and work out whether those symptoms are due to asthma or not. And if they are due to asthma, then one of the things that can really contribute to understanding that is how well the medication works for them in an acute situation. So does their reliever inhaler actually make a difference to how they feel? And even better, if you can get an objective measure saying actually, and your peak flow was very low and it's improved with that treatment. So that can give you a very good idea of not just whether somebody is having acute symptoms due to their asthma. Because, of course, many people phone up with a viral infection and their asthma
Yes.
happens to be upset by it. And it is very hard to tell the difference between somebody's viral symptoms causing a cough and the coughing and tightness in the chest that then comes on from the asthma. And peak flow, again, can give us a bit of a guide to that, because what we can do is have some objective measures that tells us what the cause of the symptoms are. And of course, you can then align that with guidelines about how severe the symptoms are and how much treatment or how fast you need to escalate things for them.
And you talked about some of those guidelines. Which are the guidelines that you predominantly use in your practice?
So we still base a lot of our work on the BTS sign guidelines. Um, of course, there are there's the NICE guidelines and the GINA guidelines out there as well, which we're keeping an eye on, especially as GINA has been updated more recently. We are in a process at the moment where BTS sign and NICE are coming together. So hopefully in the next year or so, there'll be some fresh guidelines that we can rely on in the UK a little bit more. And there's been some big changes that hopefully we will see sort of implemented as part of those guidelines to give us more clarity on how to treat our patients.
Well, thank you so much for giving up your time today and discussing those key elements around the role of objective measurements, which is really, really, really key, and also the use of the different guidelines that you use to really make an informed decision about a patient's care.
Thank you. It's been an absolute pleasure, Preeti.
Thank So, as for our listeners, we do have some further resources listed on our website, which is www.educationforhealth.org. And as always, there are some great resources on the Asthma UK website as well. So, again, they'll be available in our respiratory update pack. And we also have a free e learning modules available again on our website. So, please do feel free to access those. But again, I'd like to say thank you to Andy for taking part in today's podcast, and thank you for taking the time out for listening. Goodbye.